Welcome to everybody. My name is Rich Mitchell. I'm a professor here at the Social and Public Health Sciences Unit at the University of Glasgow. I'm also one of the phase team, this really exciting innovation which tries to put together people interested in NCDs and population health with agent-based modelers and other kinds of simulators. We've got such an exciting agenda today. So thanks for joining us. We're going to have a whole series of speakers, and there's a whole cast sitting here waiting to entertain you. And it's my absolute delight and pleasure to introduce Simon Capewell, who I've known for quite a long time now. So Simon is a professor at Liverpool. He qualified from Newcastle. He's a clinician, and I really like in his little biog that he talks about discovering public health in Edinburgh. And, you know, what a great place it is to have done that. He moved to the University of Glasgow before eventually ending up at Liverpool. And Simon manages a research programme which focuses on the epidemiology and prevention of NCDs, in particular CVD. And he's done some really interesting work looking at modelling future scenarios and explaining the contribution of different aspects to cardiovascular health. So, Simon, without further ado, I'm going to ask you to share your slides and talk away.
Thanks very much for the introduction, Rich. And so this is always the exciting bit. Can you actually see my slides?
Yes, we can.
That's
can you
great.
Actually move them?
Okay, so that's always the next thing, isn't it? So yes, so right. I can. So I've been asked to talk a little bit about the patterns of disease and prevention around cardiovascular disease, CVD. And as usual, I'll be speaking on behalf of a large team of collaborators and colleagues. In terms of the intro, I'm now an emeritus professor, which means I'm pretty much retired, and Martine does all the hard work of leading the group, which is great. But it's always been very much a collaborative effort. So in the next 15 minutes, I'm going to address 5 questions. What are the biggest drivers for non-communicable disease and indeed cardiovascular disease? They are very much overlapping. Can we say that some 4/5 of premature cardiovascular and non-communicable disease deaths are preventable? If so, what sort of prevention is most effective? In terms of the industries making the harmful commodities like tobacco and alcohol, junk food, are their tactics predictable? And in particular, there have been substantial successes in terms of tobacco control. How much are those generic? How much might they offer useful lessons? So I think the first point I want to make is that 80%, 4 out of 5 premature non-communicable disease and CVD deaths are avoidable, and that's been evident for many decades. So even if we go back to the 7 country study, then after 10, never mind 38 years of follow-up, it was very apparent that there were 5-fold differences between populations in different countries, and this had nothing to do with genetics, but an awful lot to do with the environment that people were born and grew up and lived and worked in. Likewise, if we look within populations, for instance, in the United States, then it's very apparent that there are high-risk cohorts and low-risk cohorts. So folk who are diabetic, who smoke, who have high blood pressure, etc., their event rates, their death rates are 5-fold higher than those with clear risk factors. And the genetics have been examined very carefully and play a surprisingly small role. So if 4 out of 5 premature deaths could be prevented, why on earth not? Well, there's also sorts of things going on. So let's think about what actually drives the burden of cardiovascular disease and NCDs. In broad terms, particularly when talking with colleagues, I find the 40-20-10-5 rule is quite helpful. And you'll see the reference. This is from the Lancet Global Burden of Disease Studies, a massive amount of work, which I can talk about more later if you wish. But And 40, 20, 10, 5 goes like this. So 40% of the cardiovascular and non-communicable disease burden can be attributed to poor diet and obesity, 20% to smoking, 10% to alcohol, and 5% to inactivity. Those are obviously broad figures. They vary a bit from population to population, but it's pretty consistent and worth stressing. So in terms of bangs for buck, we really have to think very hard about junk food, sugary drinks, and obesity if we're going to get a handle on this massive burden of disease and indeed inequalities. So the risk factors can make powerful differences across different populations. I'd like to show you that prevention, the evidence that prevention is powerful and rapid and equitable and cost saving. And I'm talking about primary prevention here. I'm talking about population-wide interventions. They can be very rapid. So Martin and I got a paper into the Lancet just over a decade ago, demonstrating consistently that the reductions in death rates can occur within months of population-wide changes in smoking or diet or preventive medications. So this myth we get from the industry, from some politicians, that it takes decades to turn the boat around, that's absolutely not the case. So if we think about changes in diet, then the changes that happened after the wall came down in Eastern Europe were quite striking and quite quick. So within 5 years of the wall coming down, the loss of subsidies for animal fats, the large increase in vegetable oils and indeed fruit and veg, those death rates dropped by 25%. And you can see that that drop started immediately. Likewise, if we think about hunger winters, then during the Second World War, places like Norway, the Netherlands, appalling restrictions on food, close to famine, and death rates from circulatory diseases fell like a stone and fell immediately. So, and also for the aficionados of the tobacco control story, Helena, Montana is an isolated place in the States where they had one coronary care unit. And within the town, they got smoking restriction, smoke-free, and after that, smoke-free, the admissions to the coronary care unit dropped by 40%, and that dropped within a few months. And then for those who like the politics, there was a different administration the following year. The Republicans, they rescinded the law, and up it came again. Powerful, rapid, equitable. Hilary Graham and I managed to get this into PLOS medicine again just over a decade ago. We asked the question, will non-communicable disease prevention widen health inequalities? And again, we looked particularly at cardiovascular disease as one of the numerically dominant ones, but also sharing risk factors with most other NCDs. What we found is that high-risk strategies that pick out individuals for screening, treating, they typically widen social inequalities. And I think pretty much everybody on this webcast can work out why. It's because it requires an agentic response. The individual has to pick up the message, decide to make the change the behavior, and sustain it. And we know there are massive social gradients in terms of the ability to do that and the persistence. Conversely, when we look at population-wide policy interventions, that usually narrows the gap. Why? Well, we're changing the entire environment that folk live in, and we're not dependent on an individual behavior change. It's just the default becomes the healthier option because it's a structural change. And since Hilary and I published this, there's been a stack of further evidence to support the general principle. So powerful, rapid, equitable, and also cost saving. So Ben Franklin got it right. Basically, he said that an ounce of prevention is worth £1 of cure. And in the good old days, there were 14 ounces of in every pound. It's gone up to 16 now. And this is what we demonstrated in a systematic review that went into JEC. It's been highly cited since then. We were looking at the return on investment of a wide range of public health interventions. And what we found was that public health interventions are generally cost saving. The average return on investment is about 14 to 1. However, that goes up to 50 to 1 for a structural change like like smoke-free legislation, for instance, and even 100 to 1 for something like reformulation of salt, the campaign that ran in the UK up to 2011. So massively cost saving, however one wants to define that. So 4 out of 5 cases of premature death from cardiovascular or NCD are avoidable, and we've got powerful, rapid, equitable, and cost saving if the prevention, the primary prevention, is done on a population-wide basis, changing the environment, the structural approach. So what can we learn from things that have gone right in the past? Well, I think there are some key principles that are worth emphasizing here. One of my favorites is the 3 A's, that in terms of changing the environment, you need to think about affordability and accessibility and acceptability. This approach was developed around experience with tobacco control, but when a very brief pause and reflection will show us how true that is for alcohol, for sugary drinks, for gun control, for many other things. So for tobacco control, for instance, in terms of affordability, you push up the tax, you push up the price, you stop smuggling, which might otherwise undermine pricing. In terms of acceptability, not just advertising bans, but smoke-free. Older people in the audience will remember when it was still normal to go into a pub and smoke. And everybody said, you can't do that. You can't do that in Ireland. You can't do that in Italy. In fact, you jolly well can, and you get support from a surprisingly high proportion of smokers. Then access, licensing the retailers, age checks, all that sort of thing. And lo and behold, when we think about alcohol control, the same sort of principles apply. The same applies for sugar as well. The next principle I'd like to emphasize is what I call the effectiveness hierarchy of preventive interventions. And again, I'm going to show you some evidence for smoking, for alcohol, for salt, and so on. But it seems to me that there is a universal principle here, at least quite a ubiquitous principle. So in terms of terminology, I think everybody on the call is familiar with this idea of the upstream downstream business. So doctors and nurses spend a lot of time dealing with the late consequences of disease, pulling people out, drowning people out of the stream one by one, and applying the best possible treatments and resuscitation as in intensive care. Wouldn't it be better if we stop people falling into the disease pathway at the top? So here we have somebody who's about to stumble into the stream. Wouldn't it be nice if we had a railing? Here we have an evil capitalist in a factory somewhere, in a very unhealthy work environment, generating disease in the workforce. So upstream policies, regulations, taxes, that sort of thing, these consistently achieve a bigger public health impact than downstream preventive interventions targeting individuals. And that is the effectiveness hierarchy. For many people working in health, public health, it's blindingly obvious. But as soon as we get outside of our little village, this comes as a bit of a surprise for colleagues in the policy world and the clinical world. So I'm going to quickly show you a series of slides that all demonstrate that as you move from downstream to upstream interventions, the size of the population, health benefit increases. And it's just apparent in so many things. So this is a tobacco control score, for instance. You get some sort of return on investment, some sort of effect with advice to individuals or online quick line advice or whatever, better with partial bans, more with a total ban on advertising. But when you actually get into the smoke-free laws and the pricing, then up it goes, much bigger effect. And then likewise, if we think about trans fats, for instance, hidden in so many junk food stuffs until very recently, then things get progressively better as we move from depending on the individual response to read a food label, make sense of it, and change behavior through talking to individuals, all the way up to multi-component and legislative interventions. And guess what? When we did a systematic review on dietary salt interventions, we got very much the same effectiveness hierarchy, going from worksite interventions for individuals through tax to voluntary and mandatory interventions. So wouldn't it be simple if everybody in the world wanted to increase public health and prolong life and so on? There are powerful vested interests, of course. And when we think about the industries producing the junk food, sugary drinks, the tobacco, the electronic cigarettes, alcohol or inactivity, then those are big industries. The good news is that the experience from tobacco control seems to apply across the board. So
5 minutes.
That's 15 minutes, is it? Yeah. Thanks. So when prevention policies threaten profits, so they use the same, they roll out the same playbook time and time again. And I find it helpful to remember those tactics as the harm's mnemonic. And having identified this behavior, we can predict it and we can beat it. We can anticipate the arguments in advance. So the tactics used by all these harmful industries, HARMS. So H stands for heaps of money for politicians and journalists and scientists. A is for attacking the public health advocates and groups. R is for recruiting cronies, trade industry and trade associations and so on. M is for misinformation, and S is for substituting ineffective interventions. So if we just think about the top and the bottom of those, so lots of money moves from industry into the pockets of politicians, journalists and scientists. And the problem is it's not just over the table, it's which can be traced and identified by declarations of interest, the stuff going under the table as well. And we've seen that so much with the current Westminster government, the revolving door, the contributions to political parties and so on. If we think about the bottom bit, then we've got a lot of industries now who pretend to be the public's friend and want to be helpful, but when we actually analyze what they're doing, they're pushing stuff which they know is either weak or ineffective, education, public-private partnerships, and they often put quite a lot of money into it, and with the very deliberate intention to postpone or possibly sabotage more effective interventions like legislation or taxation. And you see this time and time again as they dodge and weave. So what have we got? We're on to the conclusion slides. I've got two conclusion slides. Even in this brief time, I hope I've provided some evidence to suggest that the major drivers for cardiovascular disease and indeed NCDs are poor diet and obesity. That's greater than the sum of tobacco and alcohol and physical inactivity. A lot of these deaths, the premature deaths, are preventable, particularly around cardiovascular disease and cancer. and there's lots of evidence to demonstrate that. If we change the environment that we live in with structural interventions, population-wide prevention policies, then they can be very powerful, they can be rapid, they can be equitable, and they save potentially a lot of money. We know how the industries producing gambling, fossil fuels, junk food behave. They all behave in the same way with these harms tactics, so that can be anticipated and preempted. And we can celebrate successes in terms of tobacco control, and that gives us valuable lessons to apply more broadly, things like the 3 A's and the effectiveness hierarchy. So I apologize for rather galloping through that. I think the good news is that Rich has got these slides and will be happy to share them with anyone in the audience who so wishes. So if I can fiddle around a bit and stop sharing, over we go to you, Richard.
That's terrific, Simon. Thank you so much. And it didn't feel at all like a Gallup account. It was really interesting and really considered. So I'm going to encourage all the participants to drop their questions into the Q&A section, which you should be able to see in the toolbar there. And we already have a question from Noor. And hi, Noor. Yes, it's nice to see you again. He says that was an inspiring talk. How would you convince our ICBs on the inverted commas prevention agenda, where the focus is more on care sides to meet NHS priorities? I guess that's about the balance between focus on clinical treatment versus upstream prevention. What would your thoughts be on that?
I guess I would not spend too much time or effort on that because it is relatively difficult. And also when talking with clinical colleagues, when the word prevention comes up, they naturally think about secondary prevention and tertiary prevention. They think about the levers that are within their grasp. So identifying somebody with raised blood pressure, calling it hypertension, getting this poor person on therapy for the rest of their life, and so on. Clinicians also are a bit skeptical about primary prevention because they're worried that some of the resources might go away from essential healthcare and into another ballpark. And as I think most people on the call appreciate, the big powerful levers are in the hands of Treasury, they're in the hands of the Department of Trade and Industry, they're around advertising controls and so on, DEFRA. It has to be a government-wide and it has to be very high cabinet level to make a difference.
Thank you. While we wait for some questions to come into the Q&A, I was just thinking about, I mean, I've known your work for a really long time. You've been modeling CVD in different ways for a long time. And I guess, we're in an era now where we're trying, population health and epidemiology is experiencing these individual level kind of ABM interactive models. But what do you think are the aspects across your career of CVD which have been hardest to model in the work that you've done, and why is that?
Well, initially it was behaviors. So when we started out with the original impact model in sort of 1996, 97, we had data from Monica surveys and things. So we could get handles on population blood pressure, smoking rates, and cholesterol. And it took us quite a long time and quite a lot of effort to go upstream from the smoking rates to sort of smoking behavior, from blood lipid levels to dietary intake, and appreciate that wasn't actually about people eating cholesterol. It was about people eating a healthy diet or otherwise. The other challenge for us was to start stratifying by socioeconomic status, and that's where Martine really came in. Martine arrived in 2006, and immediately our research went up to the next level, and he will shortly be describing some of the stuff we've been doing more recently. So, but now we're much more comfortable about looking at the upstream, say food intake, and looking how that translates into cardiovascular or NCD burden. And over the last 2-3 decades, there has been this explosion in evidence. So we're now much more confident about what sort of policy changes might result in X% reduction in ingestion of sugary drinks, or Y% reduction in smoking prevalence. So it's life is a whole lot easier in that respect.
Thank you. I'm sure I know some coders who might not agree with that. So I'm seeing some messages that some people are struggling to pop things in the Q&A. So I'm going, Charlotte, whoever you are, I'm going to enable you to talk, and because you've got your hand up, and I'm assuming you're going to ask a question. So hopefully you are. So Charlotte, you should be able to talk now. What's your question for Simon? If you're there.
You're muted, Charlotte. Is Charlotte still muted?
Yes. Okay, well. Okay, but maybe that's not going to quite work. So Charlotte, perhaps you can try to drop your question either in the chat or the Q&A. But in the meantime, a great question from Johnny Stokes in the Q&A. Where do you see place-based interventions fitting here? Are they somewhere in the middle on the agentic or structural scale? I suppose, is that agency or structure for place-based interventions?
I guess I agree. Place-based is somewhere in the middle. So you can have regional or local authorities that can have quite a lot of influence on making a local environment healthier, but their job is so much easier if there is national legislation and regulation and indeed funding to implement those changes. And so at the moment we have this bizarre situation where there are lots of health authorities and north of the border health boards trying to do the best they can with the government in Westminster, which is actually rowing very hard in the opposite direction. Yeah, it's a difficult, that kind of, devolved parliament is an interesting natural experiment opportunity, but also for the people on the ground, I think it can be a bit of a struggle. Okay, thank you very much. So we're going to move on now to our next presenter. Thank you, Simon, so much. A virtual round of applause for you. And I'm going to invite our next presenter, who is the person who has been billed well by Simon. It is Martin. So he is a professor of epidemiology in the Department of Public Health and Policy at the University of Liverpool. And this is the best I can do for an agent-based modelling joke, right? But in your biog, Martin, it says that when you were training as a physician, you promptly realised that the same patients appeared through the same door in the hospital over and over again. And I was thinking, well, as a coder, that's great, isn't it? Because it's not too much complex code to make the same people in your models appear again and again and again. It's hard to write an agent-based modeling joke. Anyway, Martin, over to you. And if you could share your slides, please. And I will give you the 15-minute nod.
Perfect. Brilliant. Thank you very much. Let me start this. And yeah, I love that. This is why I'm in the UK, right? Yeah. So I get so frustrated about that little do loop. Yeah. Come back to see if we can find different ways of trying to tackle that issue, which is essentially is what we think prevention should do. So my talk would be, I titled my talk as Understanding How Powerful Prevention Can Be. And it is a very hard question. So I will try to go briefly through how we tackle these difficult questions with a modeling approach. And to start, what Simon just presented, all of that is based on this. It's just now probably 50, 60-year-old idea of Jeffrey Rose that essentially tackling the causes of the causes is going to be very powerful. And I think building on that paradigm is that we based our modeling work. And so in this talk, I will tackling a hard question, which is going up to the center of the debate we just have presented by Simon regarding the impact of structural versus individual level strategies. Then how we evolve our thinking to develop tools to support thinking about policies, not just use models as a normative way of making decisions, but also how can we help them to this users, potential models to use this and thinking tools. But then, and just on the theme of the workshop today, sometimes we started to find a problem when we talk about preventing CVD, and that is that we can be very successful in preventing CVD, as Simon said. We can really be very good. We can really expand the lifespan of people, but that creates another problem, which is the challenge of multiple conditions. So I will glance at a bit of work we are doing at the moment on that. Unfortunately, not much to show, but soon you will see some of the fruit of some of these work. So in order to tackle these difficult questions, we initially use at the beginning a variation of the population attributable risk fraction approach, which takes, with some tricks, we could accumulate some time trends on that. But essentially, the population attributable risk fraction approach assumes that the complete or partial removal, but ignores a lot of the dynamics of the population dynamics that happens in the distribution and the timing of the appearance of different non-communicable diseases. And we know that these lag times are very different. So microsimulation added us to some of these benefits, particularly allowing for lag times between exposures and disease incidence. And that was an important part of what motivated for some of the work we did with Simon in understanding how fast cardiovascular disease prevention initiatives can talk. But then we discovered that from some other diseases, the lag times are different. Even diseases that can be linked to this paradigm that essentially a combination of alcohol, tobacco, dietary and smoking policies can substantially reduce the burden of NCD. Yes, it can, but the time spread where these benefits will be accrued will vary. Also, a microsimulation allows us for the accumulation of risk. For example, if you take into account that smoking histories are very complex, and assuming just a simple yes or no question may not describe the processes in there, allowing for consideration of differential risk for subgroups of the population, and that's particularly to start to engage in the conversation about how to reduce inequalities. Provide also more detailed risk dynamics, and so diseases being risk factor for all diseases, and this is where we can fit this idea that, for example, a disease that is rapidly disappearing and extending lifespan can open the window for other diseases to appear later in life that will require our attention, and also allow us to simulate multiple disease pathways rather than discrete disease states. So we can have model multiple diseases, and we can model different stages of diseases that are more precise definitions of some of the policy interventions that we wanted to understand. And just a summary, a very high-level description of what we did with the impact NCD microsimulation model. We basically use this paradigm. We are modeling disease incidence, disease occurrence, or basically prevalence, and we can track individuals with the disease. And then we model the disease case fatality. This simple paradigm allows us to talk about prevention, talk about acute care, and talk about chronic management of different conditions. So this is the framework. We're not completely there yet, but we are working towards to fulfill the entire paradigm. So in very simple terms, we are simulating individuals, and we define a synthetic population in terms of age, sex, and socioeconomic status. We then assign them a series of characteristics that all of them reflect different causal elements on NCD production, like, for example, dietary factors, behavioral risk factors, and some biological risk factors, all interrelated in a causal way. And that's the lucky of working with cardiovascular disease. It gets more complicated when you start to add other diseases. And then we model the disease outcomes, the appearance of coronary heart disease or stroke, and then you walk through the model towards your death from specific cause or death from another cause. So basically a competing risk frame. Because of the structure of the synthetic population and how dynamically all of these factors drive population evolution, we can incorporate a cost, because we can track a certain tariff over time based on the diseases that the individuals are presenting. But also we can talk about equity, because all of these elements are stratified by a measure of social class, in our case, the index of multiple deprivation. So we have used this tool to try to tackle the paradigmatic research question in terms of what's contribution of structural, what's contribution to individual level interventions to preventing cardiovascular disease. And the opportunity came with the opportunity to put into context recent advances in dietary policy in the UK, like, for example, salt reduction and the sugar tax and smoking policy, with a large initiative, higher risk individual level based initiative to reduce cardiovascular disease, the NHS health checks. So we created, the first time we used the impact density framework was with this particular example that we published in PLOS Medicine. An interesting aspect of this paper is that our guiding question is trying to answer the how-to questions that have to be relevant for discussing the reduction of the NCD burden in the future. Essentially, the interventions, we need to speak about the intervention's ability to reduce the CVD burden, the intervention ability to reduce the equity gap, and the intervention's ability to reduce the stress in healthcare system, probably measured initially as money, as cost and cost effectiveness. So we model these two big scenarios. One is the implementation of the NHS health checks. The other is these three structural-based policies happening at population level and tackling upstream determinants of the risk of cardiovascular disease, tobacco policy, salt reduction policy, and the sugar tax. And we put the results in this graph. If you notice this graph, I hope you can see my cursor. In the y-axis, we have the probability of a particular scenario of being cost-effective. And in the x-axis, the time where this particular scenario will reach this arbitrary threshold of 80% chances of being cost-effective. So the first scenario we look is the current implementation of the NHS health checks. And as you can see, while the probability of cost-effectiveness increase over time, as outcomes are starting to accrue, it's unlikely that the current implementation would have reached a reasonable probability of being cost-effective. If we optimize the NHS health checks, well, while it will take a while, from 2011 when we started simulation to in around 2028, an optimal implementation of the NHS health check program would be cost-effective, would be value for money. However, when we look at the implementation of these structural policies, policies on sugar, salt, and tobacco, and based on what we know about the lag times between modifying these powerful drivers, as Simon showed us in his presentation, we start to accrue these benefits. We should start to accrue these benefits earlier. So essentially, they will become cost-effective far more. There's a bit of a trick here, because cost-effectiveness is about cost, is about outcomes. But believe me, if I show you the numbers, these structural policies deliver both cost savings, so it's basically saving us money, but also is delivering a lot of life saved, and particularly among premature deaths. A similar question is, can we reduce inequalities? And the graph is relatively similar. In the y-axis, we have the probability of the policy to becoming equitable, and on the x-axis is the time when that will happen. And again, the optimal level implementation, it's unlikely to get to reduce health inequalities, but when the current implementation is combined with these structural policies, we will see higher likelihood of attaining, of reducing health inequalities at an earlier time. So I think that the important thing about this is the reflection on two policy outcomes that are important, which is not just the cost effectiveness and how equitable are going to be these policies, but also when we will reach those targets, which is important for policymakers. This initial work led us to an AHR-funded project where we were commissioned to develop a simulation model to evaluate the NHS health checks. Interesting innovations in this work was that we have co-produced the model and the scenarios with a large and broad stakeholder group, including the government, at that time was Public Health England, including some of the charities like the VHF Foundation and Dementia UK, people coming from, at the time, the CCGs and local authorities, and of course also academics. And we work with them, and particularly with local authority representatives who are the responsible for the commissioning of the program and in terms of co-producing the scenario. But we also added more diseases. We added essentially obesity, diabetes, obesity-related cancers, and CKD, because again, the type of interventions that we are going to model with this model, and particularly structural interventions that can be modeled with this model, will influence a lot these other diseases, particularly diabetes and CKD, which will be the result, for example, of optimal blood pressure control and obesity reduction. We also have more updated costs for the program. We have also particularly better uptake data and participation data, particularly by IMD, because one interesting thing that happens during the NHS health checks is that people start to, without much evidence or much planning, targeting that to the more deprived parts of the population. So the uptake, paradoxically, the uptake of the interventions in the data show that it was generally more uptake for the NHS health checks in deprived communities compared to non-deprived communities. That was an empirical piece of evidence that we got at the time. But also it offers us the opportunity to a more detailed representation of the healthcare-based primary prevention program. Essentially, we can replicate better at the invitation stage, the uptake stage, the prescription stage, and the follow-up stage. So we developed the tool. You've seen the reference to the NIHR report. The code is also available. It's an open source code, and there's a very detailed description of how the model operates there, so we will not go into details. But the Department of Health took this tool, and in the statutory review of the NHS health checks, they use our tool. We haven't intervened in this analysis. We just produced the tool with the necessary functionality for them to operate. And try to answer the question on how the program can be redesigned, as it is a statutory requirement. There was political will for the program to continue. The program needs to be redesigned. So the tool provides them with some interesting information to try to estimate the return of investment, but also the probability of reaching that return of investment by a certain time horizon, the probability of reaching cost effectiveness by that time, as well as the probability of reducing health inequalities. So we managed to sell this idea of these three goals. So the effectiveness, the saving money, and the impact on equity, and provide that then as an outcomes framework that they can use to help their thinking. So when they look at the different aspects of the different scenarios they evaluated, when they look at current implementation with this updated model with more diseases, there's going to be a return on investment of about £3. It's potentially reachable, this return on investment we observed before 2040, but it will never be cost effective by the current threshold, and may have a chance of reducing health inequalities, in particular because the current implementation has been shown a targeted element to it.
5 minutes.
Yeah, thank you. So the other scenario was the reduced age of invitation. Again, a return of investment around £2, but it's unlikely to be that return of investment will realize by 2040 or cost effective by 2030, but has a chance of reducing health inequalities. If we continue targeting to most deprived and we try to reach even more deprived people, surprisingly, the return on investment will be high, but it will take more time. The population will expand significantly, therefore it will be economically less profitable. And probably we have already reached most of those people who can benefit from that with the current implementation. Please notice that the comparator is the current implementation. If we make it almost a universal screening system with high efficiency and high uptake of 90%, it still will have a good return of investment. It could be that return of investment observed before 2040, but it will be too costly, and it has a chance of reducing health inequalities, and probably because now we are achieving these across the entire population, working almost as a structural policy. And finally, they tested improved follow-up, whereas the current implementation, compare against the current implementation, which was on a return of investment of 5.1 pounds, likely to reach that return of investment by 2040. It could be cost effective, because this is one of the things that the program was not doing very well, is just follow up on what they were discovering, but it's unlikely to reduce health inequalities. So my choice, for example, about using this framework for outcomes, it would be that if I need to contain working with the NHS health checks, probably my choice will be to maintain the current implementation and improve follow-up. That will be probably hitting most of the goals that I have with a program like this. A part of thinking, really, the scenario that hasn't been explored, that will be what would be this investment. There's an argument in these results against this investment, because it seems to be returning some money down the line and reducing health inequalities, but it's not cost effective. If we have a more cost effective policy that will generate similar return on investment and reduces health inequalities by the same amount, probably you will consider this investment and redirect the funds to another area. Finally, as we were discussing this work and looking at this work, we start to find out that because we can reduce CVD so rapidly and so effectively, and particularly with structural interventions, that it tends to extend the lifespan of people. Luckily or sadly, at the moment we are observing stalling in life expectancy, so this is not much of a problem. But if we do all things right and we reverse some of the changes that are stalling life expectancy, particularly around cardiovascular disease, the picture we will have is that the lifespan should be starting to extend. But with that, increase the risk of developing further disease down the line. It is true, a lot of diseases are preventable, but having said that, they still will take a time for appear, and the benefits of the prevention will be observed really further down the line. So adding this dynamic view to policy decision making becomes increasingly important, because current health systems and research is primarily focused on preventing single diseases. Most of our programs are single disease focused, and we don't really understand when we talk about prevention, in particular in sets of interventions for prevention, what would be the impact, not just on a particular disease, but in the whole burden of disease of a population. And this is where the things becomes tricky, and this is where simulation framework help us and this is important. On the other hand, is that one of the tasks of prevention that is being discussed right now in policy agendas is help in the survivability of the NHS and the sustainability of the NHS by reducing demand. So therefore, having a tool like this will be essential to try to contribute to those debates. And what is interesting from the idea of what we are seeing in the epidemiology of living with multiple conditions, which is a basic, relatively mild conditions, but also more complex clusters of conditions, what we call basic and complex multimorbidity, is that the incidence, as Simon shows at the beginning of his talk, that the incidence between different social groups is different, and between different age groups is different, but particularly between different social groups, which suggests there is an element of preventability. I will not bother you with the complex analysis of this. You can read our papers on that. But we have basically summarized the arguments that living for multiple conditions could be substantially improved. We can delay or postpone the commencement of the accommodation of multimorbidity, and that should provide interesting relief for the health system. And the arguments are based on these trends on living with multiple conditions, starting to show a trend on younger age of onset. Since 2011, there seems to be an earlier onset of people that can be categorized as living with multiple conditions. And that happens in a reasonably small period of time. The existence of social gradients, not just in prevalence, but in incidence, suggests that the drivers of the accumulation of multiple conditions are also preventable. And we know, because we know the conditions that we are looking at, many of these conditions are effectively preventable. So now, in collaboration with the Health Foundation, we have added additional, even more diseases to our model, guided in this case by the Cambridge Multimodality Score, because the interest is also to look at the people living with long-term conditions. So this is the list of conditions at the Cambridge Multimodality Score, and we included all of these in our model. This is a report that's going to be out probably next week or the week after, where we use this model to make some projections of people living with multiple conditions. But the the goal of the model is to explore questions around how prevention strategy, either theoretical or specific policy option combination, will impact on the challenge posed by having a large pool of prevalent people living with multiple conditions. And that is because the dynamics of multimorbidity are complex. So this is occurring at different stage, different preclinical periods, and with different an incidence that is differentially expressed in the population by social class, which means that the policy targets and the policy opportunities may occur at different stages and different points of this disease pathway. Also, to accommodate these challenging prevention agendas are from moving from one disease model to tackling disease determinants for multiple diseases. And finally, not just the goal should be reduce the burden, but also how to postpone or how long we can postpone disease burden are becoming increasingly importantly policy goals. Because again, we're talking about here just to postpone the inevitable occurrence of the accumulation of disease by gaining time using prevention to shift some of resources away from specific uses in the healthcare system. Because as Simon said, that prevention may happen outside the healthcare system. Therefore, we can concentrate later on tackling the inevitable burden of diseases that we cannot prevent and that will expand because of population age. So just to finish, I think our work has been shifting from just explaining to try to convert our tools and policy on thinking tools to support policy designs. We've learned about the leveraging the benefits of microsimulation over this work. And also we learned that accurate population simulation and accurate and detailed population simulation of population dynamics have policy implications, particularly to understand how long-term trends and short-term shocks, interventions, impact on population outcomes. We also learn a lot about the dynamics of multimorbidity are complex. So this 80% preventability of all NCDs, it is real, but from now to obtaining that objective, it is a complex picture that we need to understand, again, because that will influence the type and the choices of policies that we're going to make. And this is helping support this idea of moving from single disease, single conditions toward multiple coexisting conditions for both healthcare policy, but also for public health and prevention agenda. And that will give us a better idea, better insights on the prevention payback. It's not just reducing 80%, by when we should expect that, and how much resources we can shift by using one type of prevention typologies to others. And I think that these three important goals of reducing the burden, saving money to make the NHS, the healthcare system sustainable, and reducing inequality, it probably requires this level of complexity in modeling in our days. Thank you very much.
Okay. Thank you so much.
Did I hit the nail in terms of timing?
We've drifted on just a little bit, but it was so interesting that I did just let you go on there. So thank you. A virtual round of applause. And in the interest of time, we're just going to jump straight to questions. So there's a couple in the Q&A. I'm not sure whether you can see this, so I will read them.
Yeah.
So there's one from Aisha who says NHS health checks are good, but they're only on offer for those aged over 40 from what they know. So if we're truly to go upstream and prevent morbidity and mortality, shouldn't we be trying to target younger people as well as promoting the culture? So is there an age issue here? And do your models allow for the point at which that prevention targeting screening stuff kicks in?
Yeah, one of the scenarios was actually reducing the invitation age, as you probably see, and it's probably not it's not a good idea in the sense that it seems that will prevent some lives, but the effort and the return of investment on that may not be good enough. I I think that this is a key question in terms of how we prevent premature morbidity and mortality in this population. I think that the key set of strategies that will ensure that goal more effectively are these structural policies on tobacco and diet, on salt, on sugar, on physical activity. So these are probably getting us to another word for prevention that I like, which is primordial prevention, and something that the American Heart Association use a lot, which is preventing the risk factors from developing itself,
Sure.
by adopting. So you can test that with our model. We have, in the context of the NHS health check, seems not to be a good idea. In terms of diet, I think probably it's not necessary to answer that question, because these structural policies will affect everyone.
Okay, thank you. And we've just got time to squeeze in one really great question. So this has come from Brent, but also Lawrence has been popping this question. It's a very similar question to me in the chat. So this is about lessons learned. So you've been working at the interface with government, and you've been taking your models to people who maybe not be modelers. What's the most important lesson that you've learned, or strategy that you can suggest around those kinds of collaborations?
Yeah, that's a good question, Brent. And hi, Brent. Very early in Philly today. I think the most important lesson was to understand what were the policy needs, what were the decision needs. That was the first one. When we were developing the workhouse model, we took a lot of time to understand what were the constraints, where they were operating to. The second was to create trust with them. I remember in one of the initial workshops that we have done, there were a group of people coming from Public Health England that were very anxious and suspect that we can make our model tell a particular answer. So we can, for example, say initially disregard the effectiveness of their health checks, because, well, we think we have been always working on structural policies and making the argument that they are very powerful and equitable. And we show them that the model is agnostic to that sort of thing. It's replicating the epidemiology. We take a lot of time, and it actually is true. It is replicating the epidemiology. The third one was that they understand what we mean by modeling, and they understand what data is going in, what assumptions we are making, and how can they operate the model. That means creating that relationship that creates trust. And the final point is to identify potential use cases for them, to see how beneficial it's a tool for the decision processes. And that's why, for example, the final workshop was about co-creating these policy scenarios with the stakeholders, and just play live those scenarios with them and with the tool. So it's about serving the client, it's about understanding the policy constraint, it's about speaking the same language, it's about being honest and show that the model will provide trustable answers, and making them be part of the process of creating the tool.
Oh, that's a lesson for an awful lot of science, not just the kind of modeling that you do. Thank you so much, Martine, and an enormous virtual round of applause for you. Thank you very much. So in the interest of time, we're going to move straight on. So it's great value phase, because not only have we got one speaker now, Nathan is ably assisted by James and Lola. Nathan is a professor in the Department of Computer Science at the University of Warwick. He's previously been a Turing Fellow and a Royal Society Industry Fellow. And he is an agent systems modeler. He's got some really interesting research interests. His interest page is worth checking out, just because of the range of things that it covers, from trust to social norms. And he's been working as part of phase on questions closer to the heart of us people who work in population health. So Yuthi, I'm not quite sure how you're going to run this. So I'm just going to hand over to you, and I will holler when you've had 15 minutes. So thanks very much, and over to you guys.
Okay, so yes, this is a bit of a tag team presentation. So this is an overview really of a short pump priming project funded by phase. And it's a collaboration of two computer scientists, stereotypically the two males of the team, and a public health expert. So you'll kind of get that James and I have quite a different background and perspective, I think, from the other speakers. So the aim of our project is to use agent-based modelling to model the sort of risk factors for cardiovascular disease, and in particular the way that these risk factors might kind of spread through a population. So the sort of four main factors that we consider: so smoking, drinking alcohol, lack of exercise, and poor diet. Hopefully it's not contentious to say that whilst CVD itself is not communicable, the behaviours, or at least attitudes towards those behaviours, have a social aspect to them. So there's an element of sort of social spreading in terms of the way those behaviours might influence individuals. So from an agent-based perspective, we model this as a kind of influence spread throughout a population. And so we define a population of agents, each of which has got attributes that we sort of try to fit to real-world data. So clearly it's a simplified population. The agents have an age, they have a sex, they have an index of deprivation, and they have an employment status. And we model 4 different kinds of relationships between the agents to get our sort of population. So the first kind of relationship we have is spousal. So we model marriage, then we model households. I should probably say that we make a simplification that we're only considering adults, and in fact we're only considering up to age 89, just for sort of simplicity here. So we have spousal relationships, we have household relationships. Clearly individuals' attitudes to smoking, alcohol and so on are influenced by their spouse and arguably influenced by their household. The other 2 kind of relationships that we model are friendship and work colleagues. And I think, to be clear here, we're modelling close friendships, so where there is likely to be sort of a definite influence from one individual to another, and similarly close workplace contact. So not everybody who works in the institution you work with, but perhaps the people who work within your team. And the idea is that we can simulate how the risk factors spread throughout these different kinds of relationships, which will allow us to simulate behavioural interventions. So each agent has a sort of level of engagement, if you like, with each of the risk factors that are contributing to CVD. And then we have a round simulation. Each simulation round can be kind of considered a year of real time, in which agents influence those that they're connected to through these 4 different kinds of relationships to either increase or decrease the level of engagement with the different risk factors. Then, based on the current levels of those risk factors, we calculate the probability that an agent might have a CVD event. We determine whether an individual does have a CVD event, and if so, they get removed from the simulation. Then the remaining agents increase their age, because age clearly is an important factor, and we crank the handle again. And so we run this simulation over time. So now I'm going to hand over to Lola, who knows much more about the data and can talk about that in a much more informed way than I can.
Thanks, Nathan. So yes, I'm popping up to talk about my side of the project. And so Nathan and James did the architecture of the model, and then they had parameters which they needed data to base those parameters on in order to make the model realistic. So I was seeking the data to inform the parameters, and I had 2 people to help me with that, a research assistant and a public health registrar. And what we did in principle was, where possible, we used nationally representative data from the UK or England to estimate parameters, and as recent as possible. And for some of those parameters, it was really very easy. So you can see for the agent characteristics and networks, one of the data sources was the Office for National Statistics population estimates. And so we've got really good data on age and sex, for example, for the population. And similarly, the agent behaviour, we use the Health Survey for England for most of those, so for alcohol and for diet and cigarette smoking. And we use the Active Lives survey for physical activity. And those are good data sources that give us some representative data that tell us about the prevalence of those behaviours in the population. But there were other parameters that were harder to find. So, for example, the number of close friends that a person has. So we could find various different research studies on that, but we ended up using this YouGov friendship survey from 2021, which asked people about how many close friends they thought they had, and did that by sex and by age groups. But yes, there were lots of different possibilities, and they don't always necessarily match with when we then look at the data of how the friends influence each other. It's not necessarily the same question that was used. So there are some assumptions that are made all the way through. In terms of influence spread, we use these 4 papers that look at, so they're listed again in this table that you can see, that look at the spread of the 4 behaviours through social networks. And finally, we used QRisk3 to determine the risk of a cardiovascular event for each agent based on their characteristics. So if you go to the next slide, James, yeah. So in terms of the table on the left, this is just to show that for each agent, we gave them a level for each of the 4 risk behaviours that were studied. And this shows you what those were. So, for example, for cigarette consumption, then we had never smokers, they were 0, then ex-smokers at 1 and current smokers at 2. So actually cigarette smoking was the peculiar one. So for all of the others, agents could move from a level 0 to a level 1 to a level 2, back to a level 1, back to a level 0. But for smoking, people moved from 0 to 2 and then back to 1, and they could never then get back to 0 again. And we used levels that are very easy to find in terms of the literature. So 5 portions daily for fruit and vegetables, for example, is easy because that's what's reported on in the Health Survey for England, because it matches to government advice. And then on the right, that is the QRisk3, that's from the website. So you can put in all of the characteristics of an agent and you can get their risk of cardiovascular disease over the next 10 years. And so James used the algorithm behind that to determine the CVD risk for each agent. Can look at the next slide now, James. Yep. So finally, just to say, this is another one that was difficult. So I talked about the fact that age and sex were, quite easy, and some of the prevalence of health behaviours were quite easy. Household size was something that was more complicated. We couldn't find the most, we couldn't find data that discriminated for every age and sex, for example. And so we've had to make some assumptions. And this is just really showing you how I went from the data to Nathan and James had created CSV files, like Excel spreadsheets, that I filled in with probabilities based on the data. And for some of those, there was a kind of another long list of assumptions that were made, which we recorded to explain how we got from the data to what was going into the model. So that's the end from me. And now I'll pass on to James to talk about some of the more detailed technical aspects.
Yes, thank you, Lola. So as we've said, we've tried to build this kind of simulation, and one of the things we first had to focus on was how to actually generate our population. One of our major goals here was to generate a population that could be representative of a UK city. That's why we pulled all of our data from these sources, trying to emulate distributions of a UK population. When it came to actually generating the agents for our simulations, we look at generating households, so groups of agents that we collect together in households. What this means is that when we actually make our simulations, sometimes the overall number of agents present is above slightly what we're actually aiming for. So if we try to make 300,000 agents, we might end up with 300,002 because we're generating complete households, and it might just push us slightly over the top there. But the general process for creating an agent or a household is fairly simple. We choose a first agent, we generate a first agent using our statistical distributions, and then we decide based on that agent's age and sex, are they married? If they are, we generate a spouse. Then we decide how many other occupants are in that house. And then we generate the remaining occupants, again, according to our distribution. So you can see sort of the flow chart there kind of going through. The main thing to sort of keep in mind here is that we are looking at sort of both the idea of houses that might have multiple adults in that are married. So the first couple we assume might exist. We have a married couple. We might then generate additional adults to sort of capture some of that extra data of young people tending to live together, and things like, at first we decided we might want to look at multi-generational households, but that proved quite difficult to actually pass out. So we just sort of look at average data in the UK for household size. We do have a lot of, that means we do end up with a lot of sort of two-person households where the two people are married, and then we end up with a lot of households where the initial person isn't married, and a number of adults share the space. Then we sort of repeat this process. Once we've decided on our general population for that household, we repeat this process for as many households as we need until we have the full size that we need for this simulation. We've run some tests and we can sort of generate about 1.1 million agents if needed. It takes about an hour to run that simulation. So there is a decent scalability here. Once the actual population is generated, we then need to generate the relationships. So some of those are done at household generation time, so particularly spouse and housemate, because we're generating the household. So obviously every agent that lives together is a housemate or a spouse. Then we need to also generate our close friends and our close work contacts, like Nathan said. The important thing to note here is that we treat these relationships as having a sort of strict hierarchy, in that two agents will only ever have one relationship. So any two nodes in our network will only ever be joined by a single edge that represents a single type of relationship. So if we decide that one agent is the spouse of another, that agent will also not be designated a housemate or a friend or a work contact. They will be a spouse. Similarly, housemates cannot be friends. Friends cannot be close work contacts. So we have this clear hierarchy. When we're generating friendships, we choose to generate a social network according to pre-developed kind of social network generators, right? So either a small world or a scale-free synthetic network that we know sort of can mimic some of the parameters of a real-world social network. We have the ability to sort of tweak those. So we sort of take in, again, taking data from Lola, figuring out the average number of friends that a person might have, and we generate networks to fit those parameters. So that friendship network is then sort of, you could see it as another layer on top of the household network. Then we have close work contacts. Workplaces are a little bit more complex, the way it works. So obviously, first of all, agents may or may not be employed. If they are employed, we assign them a workplace type and a workplace size. Workplace type is something that we're hoping to use within the sort of simulations to look at workplace interventions eventually. But for us, looking at the relationships, the size is the most important thing. So essentially, based on the size of a company, whether it's a small company with maybe only 5 or 10 employees or a massive company with hundreds or thousands of employees, we generate a number of close work contacts that a person might be expected to have, essentially representing the group or team that they may work in within that big company. And the idea here now is that basically every agent will have up to 4 different types of relationships and a number of other connections that will facilitate the influence spreading between agents.
You've had 15 minutes.
Yeah, thank you. So essentially the agents will influence each other based on their relationships. We're using a threshold-based model. What that means is that each agent is given a threshold selected from a Gaussian distribution that represents how difficult they are to influence. During each step of the simulation, agents will exert influence on each other through these relationships. And again, that amount of influence is slightly based on data that we first gathered with Lola from a slightly earlier project first looking at this sort of stuff, and now sort of a parameter sweep to try and find the actual right levels that we need, because we are now in the calibration processes we talked about in a moment. But we total in the incoming influence for each level of each behavior. So that's 12 different levels of influence, and use those to select the level for each behavior that an agent will adopt. If only one of the 3 levels breaks the threshold, excluding level 0 smoking for non-level 0 smokers, they'll adopt that level. If it's more, we choose based on a probability. Which means that over the course of the simulation, which may only be 10 time steps representing 10 years, an agent may fluctuate between the levels of each behavior depending on their network. Then, very quickly before I hand back to Nathan for the final slide, we originally started with our simulation written in Python. I don't know why I said originally, it still is. And we're hoping to make it public after it's been tidied up a little bit. I'm sure we all know how research code goes. The important thing to note when we built the simulation is we also included all these extra CSV files, which Lola mentioned before, allowing us to set all the parameters. We hope that what this means is that when we release the code, non-technical users can engage with the CSV files and tweak them to build up their own environments and simulations to have a look at the effects of these different relationships on the risk factors, and perhaps even looking at different interventions. And I'll sort of hand back to Nathan to finish us off.
Thank you. So yeah, so we're calibrating at the moment against observed data. So the calibration is sort of based on a random search to narrow down the search space. And then the sort of interesting question is that there are potentially several parameters that give the same results. So that's something we're kind of looking at the moment in terms of the robustness of the simulation to those parameters. So I guess to conclude, we've built this simulation that models the spread of the risk factors that impacts on CVD. It scales reasonably, so our aim was to scale to sort of a moderate sized city. I think we picked Coventry as an example, which is, I think, 350,000 individuals, something like that. So on a modern laptop, it runs for 400,000 individuals in just 10 minutes. It works for a fairly large city, so over 1 million individuals in an hour and a half. This graph on the bottom right shows it scaling on a desktop, which, yes, sure, it's exponential, but it does mean that we're reasonably confident that we can simulate a city of around 1 million individuals. And really the next pieces of work that we're looking at are starting to look at potential interventions. So I thought the first presentation today was very interesting. So one thing we might do, for example, is look at very sort of agency level interventions where we target particular kinds of individual. Conversely, we might target particular kinds of workplace, which is perhaps somewhere in between the structural and the agent intervention. And I guess a final comment is that the project's sort of drawing to a close now, and we'll be releasing the simulator publicly. And the aim is that you'll be able to run experiments by just providing CSV files to the simulator rather than editing the Python. Although, of course, those of you that are techie like James and myself can dive into the Python to your heart's content. Okay, thank you.
Thank you so much. It's so interesting to see where you've got to with this, and just a really nice kind of bookend to the earlier presentations today. So thank you so much. Do you know what? I'm going to be really cheeky, and I've got a question which I'm going to ask before we go to the questions in the Q&A, because I can. So I think I'm right in saying, Nathan, I think it was you that said that you remove someone if they have a CVD event. And I'm just kind of curious about that decision, and I suppose it's on the basis that we all know the stories of Uncle Harold, who was super fat and smoked a lot and had a heart attack, and then the rest of his family go, oh my goodness, actually it's serious, and so their behavior changes. And I'm just wondering about the extent to which an event might actually be, make behavior more contagious, or kind of have a bigger ripple effect on behavior. So why do you remove if there's an event?
Lola, do you want to answer that one? Or?
We remove if there's an event because we think that they might die, and also because, well, I think some of the data that we had was looking at people having their first cardiovascular event. Actually, I'm not sure in the latest round whether we still have any of that in there, but that was another reason that we were thinking about because we were thinking about primary prevention. So we weren't looking at people experiencing maybe a second heart attack or a further event. But I think it would be really interesting. I mean, we definitely could, with the model, we could identify the contacts of a person who's left the model because of having a CVD event, and we could change their behavior by some amount based on that. And I think that would be a really interesting thing to do. And so, that's probably in our long list of possibilities for this model that is growing all the time.
Yes, I'm sure there'll be lots of interest.
I mean, actually, just to sort of follow up on that, I guess in terms of the code, it would be a fairly small change. So if there is any published data on what the likely change of influence would be, then that would be great, because there's probably just about enough time left of the project that we could indeed incorporate that.
Sure. I mean, I guess people like Simon might be able to tell you if my guess is true. I suppose it could go the other way, and that people are very stressed by a family member or a friend being ill, and it drives them to stress-related behaviours. Anyway, enough about me. Let's move on to the questions in the Q&A. So first question from, well, that's just 3 questions from Kui Peng. I hope I've said your name right. I think you actually answered question 2 in your last slide, and this question popped into the Q&A before you saw that slide. So the first one is, how do you estimate the risk of non-CVD death in the ABM? And then perhaps the second one to answer is, does it consider birth? Is the population fixed? So I don't know, let's take that one.
So I don't think we are considering non-CVD deaths. That's partly why we capped our age at 89, which we know is arguably optimistic. But the idea of the simulation is to be able to support looking at interventions, so changing the influence. So what happens if you change levels or you have a workplace intervention? And so the focus is very much on just the CVD side. So we're only really interested in the number of CVD events at the end, rather than how many agents are left in the population. Mm-hmm. And we don't consider birth primarily for simplicity, but also because we're only considering adults. So if you do a sort of 10-year simulation, then agents that are born at the start still haven't turned into adults by the end.
But actually, we don't have any new agents entering, do we, during the 10 years that are running? So it's as if we've got a set of people that we recruit from 18 to 89, and then we follow them. And so at the end, we've got 28-year-olds and over. Yeah.
So actually, if things go badly, you could kill them all.
Some of the early ones did do that.
Yes. Okay. Thank you. And a question from Rick. Hi, Rick. Rick says, is the social network static or dynamic?
It is currently static. Again, I think for reasons of, probably 2 reasons. So partly simplicity, and partly actually there's not very much data on how social networks change over time. So there's reasonable data in the literature, although quite a lot that doesn't agree with other papers in the literature. But there are a number of papers that say this is the average size of a social network in terms of a friendship network, an influential friendship network, or a number of contacts. There's not so much information on how does an individual's network change over time. There's a little bit in terms, I've found in terms of how the number of contacts changes over the time, but not the actual rewiring that you would need to do. So you said at the start, which in that very flattering introduction, that I've got quite a wide range of interests. Actually, I think I've got a really narrow range of interests, which is all agent-based systems for a bunch of different applications. And for other applications, I've looked for this data on how social networks evolves, and there is some, but not a lot, and that there is tends to be only for kind of online social network, you know, Twitter, Facebook, and the like, which perhaps one would hope are less influential than your real life friends.
Well, that's a question for a whole other social network. Okay, that seems to be all the questions in the Q&A and the chat, and I would very much like to finish on time. And I just want to spend a moment saying an enormous thank you to all our speakers today. It's a lot of effort to come and try and give a talk to an audience of such kind of mixed backgrounds to the audience we've got. Just a reminder to all of you that Phase Network is here to try to connect modelers and users. And please check out the website, because we're continually adding new resources and new information, and more seminars remain in the series. And just to say thank you very much to everybody for attending, and thanks again to the speakers, and it was great to see you all. So thank you very much.